Welcome to Monday Morning Panic. We're actually dropping this one on a Thursday just for you. This is going to be a special, super fast-paced review. Think highly concentrated, hitting all the critical points on acid base and electrolyte imbalances you absolutely need for that upcoming nursing exam. Our goal, cover everything essential quickly and thoroughly. Let's jump straight into ABGs.
All right. ABGs are arterial blood gases. Fundamentally, they're an essential diagnostic test. They tell us about the patient's acid-base balance. And when you're interpreting them, there are really three key numbers you have to focus on.
Okay, so three numbers. For someone needing that quick hit review, what are they and what do they mean?
First up is pH. That's your primary indicator, tells you straight away. Acidosis or alkalosis. Remember, lower numbers mean more acidic.
Lower pH, more acid. Got it.
Then you've got bicarbonate or HCO3. That primarily reflects the metabolic side of things.
Right.
And kidneys, how much base are they holding on to or getting rid of?
Okay, bicarb is metabolic. And the third?
That's the partial pressure of carbon dioxide, PaCO2. This reflects the respiratory component. Basically, how well are the lungs blowing off CO2?
Mm-hmm.
Understanding how those three interact, that's your critical first step.
That clears it up nicely. So pH, bicarb for metabolics, PaCO2 for respiratory. Let's dive into the specifics then. How about metabolic acidosis? What does that look like?
Okay, metabolic acidosis. You're looking at a low pH and low bicarbonate. Clinically, the big thing is it depresses the central nervous system, the CNS.
It depresses the CNS. And how does it happen?
Well, there are two main ways, really. Either the body is making or holding on to more acid than it should, or it's losing too much bicarbonate. When we talk about increased acid, that often means a high anion gap.
High anion gap. What exactly does that signal for us?
It basically means there are extra unmeasured acids floating around in the blood. Think of it like a gap widening in the balance sheet of ions. It strongly points towards things like ketoacidosis, DKA. Diabetic ketoacidosis is the classic example.
Okay, DKA. What else?
Uremic acidosis, you see that with kidney damage, chronic or acute. Lactic acidosis, often from tissue hypoxia, like an ischemic bowel. And definitely remember toxic ingestions like methanol, ethylene glycol, or even aspirin toxicity. That's a big one for exams.
Aspirin toxicity, right. So those are the more acid scenarios. What about less bicarbonate? That's the normal anion gap, you said.
Exactly. Sometimes called hyperchloremic acidosis. The most common causes here are significant GI losses. We're talking excessive diarrhea mainly,
right.
Or maybe a pancreatic fistula.
Okay, diarrhea causing bicarb loss. So what symptoms are we assessing for in these patients?
Neurologically, watch for confusion, disorientation, headaches, lethargy. It can get really serious, progressing to coma and even cardiac arrest.
Wow. Okay. And respiratorily?
You'll often see Kussmaul respirations, at that very distinct, rapid, deep, almost labored breathing. It's the body trying desperately to blow off CO2 to compensate.
Kussmaul breathing. Got it. Cardiovascular signs.
Expect arrhythmias and hypotension. And another classic sign, specifically with ketoacidosis, is that fruity smell on the breath.
Fruity breath, right?
And here's something really crucial for you to connect. Metabolic acidosis often goes hand in hand with hypokalemia.
Hypokalemia, low potassium. Why is that?
Yeah. As the body tries to buffer all that acid, hydrogen ions shift into the cells. To maintain balance, potassium ions get pushed out of the cells into the blood, and then the kidneys excrete more potassium. So you're not just treating the acidosis, you're actively managing potential cardiac issues from low potassium. It's a key link.
That's a vital connection. Acidosis leading to hypokalemia. So how do we treat the acidosis itself?
The absolute priority is always to treat the underlying cause. So for DKA, it's insulin and IV fluids.
Treat the cause first, okay.
You might also administer sodium bicarbonate IV if it's ordered, but be careful. Monitor very closely for overcorrection. You don't want to swing them into metabolic alkalosis.
Right, don't overshoot. What else?
Severe cases might need mechanical ventilation or even dialysis. Nursing-wise, you need to monitor vital signs and cardiac rhythm continuously. Use telemetry.
Telemetry, definitely.
And closely monitor that neurologic status. Report any changes immediately. Keep GAV access patent. You might even need a large bore catheter for emergencies, for rapid fluids or meds. And track INO and kidney function closely.
Okay, comprehensive approach. Now, flipping the coin, metabolic alkalosis. Too much base or too little acid.
Exactly. Metabolic alkalosis means a high pH and high bicarbonate, the most common causes. Copious fluid loss from the GI tract. Think severe vomiting or prolonged nasogastric NG suctioning.
Vomiting and NG suction. What else?
Diuretic use is another major one, especially loop diuretics like furosemide and thiazide diuretics. Corticosteroids, too. Loop diuretics, remember, can also cause hypochloremia along with the alkalosis.
Loop diuretics causing hyperchloremia and alkalosis. Noted.
And interestingly, there's a medication, acetazolamide, that actually reduces bicarb levels. So it can be used to treat metabolic alkalosis sometimes.
Huh, acetazolamide is a treatment.
Mm-hmm.
Any other causes?
Yeah, less common things like getting too much citrate or acetate, maybe from blood transfusions or dialysis, Cushing's syndrome, or pathologically high aldosterone levels.
And what are the key assessment findings? What jumps out?
The big thing is neuromuscular irritability. The symptoms look a lot like hypocalcemia or hypokalemia.
Irritability, why does that happen?
It's because with fewer hydrogen ions around in alkalosis, more calcium and potassium ions bind to albumin. This reduces the amount of free active calcium and potassium, causing those hypokalemia-like symptoms.
Ah, so it's about the free ions. Clever. How do we treat it then?
Again, address the underlying cause. Replace fluids, correct electrolytes, discontinue diuretics and NG suctioning if you possibly can. That's key.
Stop the offending agent. Makes sense.
The overall goal is to reduce bicarbonate levels and reduce acid loss. So if it's severe vomiting, treat the vomiting. Monitor vital signs and cardiac rhythm. Assess their neurologic and neuromuscular status, looking specifically for Schwastack's and Trousseau signs.
Schwastack's and Trousseau's for irritability.
Right. And definitely provide seizure and safety precautions. Oh, and a practical tip. When you irrigate NG tubes, use normal saline, not tap water. Tap water can wash out more gastric electrolytes.
Use normal saline for NG irrigation.
Good tip. Okay, let's shift to the respiratory side. Respiratory acidosis.
Respiratory acidosis. Low pH and high PaCO2. It always comes down to something interfering with normal breathing, preventing CO2 elimination, basically hypoventilation.
Hypoventilation causing CO2 buildup. What kind of conditions?
Think airway obstruction, like COPD and asthma exacerbations. Those patients often come in wheezing profoundly, right? And they usually improve with bronchodilators and steroids.
Yeah, COPD and asthma are huge. What else?
Upper airway obstruction, maybe foreign body. Central nervous system, CNS depression is a big one. Think opioid overdose suppressing the drive to breathe. Neuromuscular diseases that cause shallow or slow breathing. And pulmonary conditions like severe pneumonia, pulmonary edema, chronic bronchitis.
So lots of potential causes. What symptoms are we looking for? Neurologically, it's depressive symptoms. Starts with a headache, but can progress to coma as that CO2 builds up. Respiratorily, look for rapid, shallow respirations, dyspnea, maybe coughing or wheezing, depending on the cause.
Rapid and shallow breathing.
Cardiovascular.
You'll often see tachycardia, arrhythmias, hypertension, and maybe bounding pulses.
Okay, so how do we intervene? What's the priority?
Priority. Treat the underlying cause of the hypoventilation. That's number one.
Fix the breathing problem.
Exactly. Mechanical ventilation or maybe positive pressure like BiPAP might be needed. You'll administer bronchodilators and corticosteroids for things like COPD or asthma. Give oxygen therapy.
Oxygen, yes.
But critically, do not give sedatives. They can make the respiratory depression worse.
No sedatives, got it.
And standard things help too, like breathing exercises if they can, elevating the head of the bed, and continuous monitoring vitals, ABGs, pulse oximetry.
Makes sense. Now, the opposite, respiratory alkalosis.
Respiratory alkalosis, high pH, low PaCO2. This comes from breathing too much hyperventilation. Hyperventilation blowing off too much CO2. Why would someone do that?
Most commonly, anxiety, fear, or pain. Makes sense, right? People breathe faster when they're stressed or hurting. Hypoxemia can also trigger it. The body tries to get more oxygen by breathing faster.
Anxiety, pain, low oxygen. Any others?
Yeah, salicylate or aspirin toxicity is an important one. Aspirin directly stimulates the respiratory center. Also, things like fever, early sepsis, liver disease, pregnancy, hyperthyroidism, trauma, even some illicit drugs.
Aspirin again.
Okay, and the main symptom.
Neurologically, it typically begins with lightheadedness or dizziness. That can progress to fainting or syncope because the low CO2 causes brain blood vessels to constrict.
Lightheadedness from vasoconstriction. How do we manage this?
Again, priority. Treat the underlying cause. If it's pain or anxiety, give appropriate meds. If it's hypoxemia, give oxygen.
Treat the cause. What about that aspirin toxicity?
Check an aspirin level. If it's severe, dialysis might be needed to get the aspirin out.
Dialysis for severe cases. Okay, for the hyperventilation itself, you can encourage controlled breathing, like breathing slowly into a paper bag or cupped hands to rebreathe some CO2.
The paper bag trick, does that really work?
It can help temporarily raise CO2 levels, yeah. But fixing the cause is key. You'll also monitor vital signs, ABGs, and serum electrolytes closely. And because of the lightheadedness, implement fall precautions. Maybe even seizure precautions if an electrolyte imbalance like hypocalcemia develops.
Fall and seizure precautions. Good point. Okay, we've covered acid base, but these issues often tie into fluid balance, right? Let's talk fluid volume deficit or hypovolemia. How do we spot that?
Right. Fluid volume deficit, FVD, just means the volume of fluid circulating is too low. Causes excessive fluid loss. Could be renal losses, making way too much urine because the kidneys aren't reabsorbing sodium and water properly.
Kidneys losing too much fluid
Or extrarenal losses from the GI tract. Excessive diarrhea, vomiting, NG suction, pancreatic fistula from the skin, heavy sweating, burns, or just plain blood loss.
GI, skin, blood loss. Makes sense.
And don't forget, simply decrease fluid intake. Maybe they're nauseous, can't drink, or just dehydrated. Also, conditions like diabetes insipidus or Addison's disease where you have low aldosterone.
Okay. You mentioned cardiovascular signs earlier. If I see a patient, what's the most alarming combination of vital signs for severe hypovolemia?
That's a great question. While you look at the whole picture, the combination of severe hypotension like really low blood pressure along with tachycardia, a fast heart rate, and rapid, weak, or thready peripheral pulses is a huge red flag. That screams significant volume depletion. Orthostatic hypotension is also very common.
Severe low BP, fast, weak pulse. Big red flag. What else?
Neurologically, confusion, lethargy, dizziness, disorientation, skin, poor, tinting dry, sticky mucous membranes, cool extremities. And renally, decreased urine output, maybe even oliguria.
Low urine output. Makes sense.
Plus, general symptoms like thirst, weakness, fatigue, maybe nausea, vomiting, or abdominal cramps.
Got it. So treatment priority.
Priority treatment. Fluid resuscitation. No question. You need to get volume back into the circulation fast.
Fluids first. What kind?
For patients who are hemodynamically unstable, meaning low DP, fast heart rate, you'll give IV isotonic fluids. Think normal saline or lactated ringers. These stay in the vascular space initially.
Isotonic fluids for unstable patients. What about other types?
Well, colloid solutions like albumin are usually avoided, maybe used sometimes in liver disease. Hypotonic solutions like D5W or half-normal saline are more for treating hypernatremia or for maintenance fluids. But there's a major warning. You have to monitor sodium levels closely when giving hypotonic solutions. Give them too fast, and you risk cerebral edema.
Cerebral edema risk with hypotonic fluids. Critical point. What else in management?
Definitely stop any diuretics if they're volume depleted. Monitor symptoms and vital signs constantly. Accurately track INO urine, stool, vomit, everything. Get daily weights.
Daily weights, good indicator.
Maintain 40 access, good access, and monitor infusions carefully, preferably with an infusion pump for control. Safety precautions are huge. Fall risk due to dizziness and weakness, and even seizure risk if electrolytes get severely deranged.
Fall and seizure precautions. And meds.
Yes, crucial point. Consider discontinuing ACE inhibitors, ARBs, or NSAIDs if the patient is hypotensive. These drugs can really worsen kidney function, bump the creatinine when someone's already volumed down.
Stop ACEs, ARBs, NSAIDs if hypotensive. That's really important clinical reasoning. Okay, what about the opposite problem? Fluid volume overload, FVO, or hypervolemia?
Fluid volume overload. Too much fluid in the pipes. Causes are often pretty straightforward. Either excessive fluid intake, like getting IV fluids way too fast, or maybe with TPN.
Too much fluid in, or
impaired fluid excretion. The body can't get rid of it properly. Think heart failure, kidney failure, especially chronic kidney disease, CKD, cirrhosis, preeclampsia. Also conditions like Cushing's syndrome or hyperaldosteronism that make the body hold on to salt and water.
Heart failure, kidney failure, common culprits. How does this overload look clinically?
Cardiovascularly, you'll feel a rapid bounding pulse. They'll often have hypertension and tachycardia. Respiratorily, this is key. Dyspnea, shortness of breath, hearing crackles in the lungs on auscultation, and potentially full-blown pulmonary edema.
Crackles, pulmonary edema, fluid in the lungs, vascular signs.
Classic sign. Engorged neck veins, as jugular vein distension or JVD, also engorged hand veins. And pitting edema, usually in the legs or dependent areas.
JVD and pitting edema, obvious signs.
Plus excessive weight gain from the fluid, maybe weakness, nausea, vomiting, headache.
How do we treat FVO?
First steps are usually fluid restriction and sodium restriction. Cut back on what's going in.
Restrict fluids and salt? Then what?
Then diuretic therapy is critical. Loop diuretics, like furosemide, are the backbone for pulling off fluid. They're usually the first choice.
Loops are the main tool. Any others?
Yeah, if sodium levels start creeping up, you might use thiazide diuretics. If potassium drops too low from the loops, you might add a potassium-sparing diuretic. And remember, acetazolamide, it can be used if the patient becomes alkalotic from the fluid shifts or diuretic use.
Right. Acetazolamide for alkalosis. What if diuretics aren't enough?
Then dialysis might be necessary, especially if kidney function is poor.
Dialysis as a backup. Nursing interventions.
Monitor vital signs, cardiac rhythm, and respiratory status constantly. Document that edema. Listen to lung sounds frequently. Track INO and daily weights meticulously.
INO and daily weights again. Crucial for fluid balance.
Absolutely. And always use an infusion pump for any IV fluids. You absolutely don't want to accidentally give more fluid to an overloaded patient. Monitor serum electrolytes closely because diuretics can cause new imbalances. And implement fall risk safety precautions.
Use a pump, watch electrolytes, fall risk. Got it. Let's switch gears to specific electrolytes. Sodium first, the extracellular cation.
That's right. Sodium, normal serum value, 135, 145 milliQL. And yes, it's the most abundant medication outside the cells, hugely important for nerve impulses, muscle contraction, acid-base balance, and really fluid balance overall.
Okay, 135, 145. What about hypernatremia sodium over 145? What causes that and why is it so dangerous?
Hypernatremia, high sodium, often caused by excessive water loss. Think diabetes insipidus, where you lose tons of water, high fever, hypermetabolism, severe diarrhea, burns, just profound dehydration. Or polyuria if it's dehydrated, oliguria if the kidneys can't get rid of sodium.
Losing water, concentrating sodium?
Or getting too much sodium, like from high chloride IV solutions, normal saline, hypertonic saline, TPN can do it. Certain drugs too, acetazolamide, kayexalate, salicylates, also diuretic use for uncontrolled diabetes.
Okay, and the dangers. You mentioned it's uniquely neurological.
Yes, the neurological symptoms are unique and the most devastating because high sodium pulls water out of brain cells, causing them to shrink. You see confusion, agitation, restlessness, irritability, lethargy, disorientation. It can progress to seizures, coma, and even permanent neurologic damage, especially if that sodium level gets really high, like over 155.
Brain cell shrinkage, that sounds terrible. Other signs?
Integumentary, dry mucous membranes, a dry, swollen tongue, flushed skin. Cardiovascularly, you might see hypertension, tachycardia, pitting edema, weight gain if it's related to fluid overload too. Renally, oliguria, or anuria.
How do we treat this?
Carefully, I imagine.
Very carefully. First, treat the underlying cause, often dehydration. Then you need to replace the free water deficit. You'll give low sodium or salt-free IV solutions like dextrose 5% in water, D5W, or half normal saline. But the warning is, go slow.
Go slow. Why?
Because if you drop the sodium too quickly with hypotonic fluids, water rushes back into those shrunken brain cells, causing cerebral edema, which is just as dangerous.
Cerebral edema risk again. So slow correction is key. Absolutely. If the patient is also hypovolemic, you might start with isotonic saline or LR to stabilize their pressure first. Restrict sodium intake. In extreme cases, hemodialysis might be needed. And you absolutely must monitor for signs of cerebral edema headache, worsening confusion, irritability, nausea, vomiting, a drop in pulse rate, seizures while giving those hypotonic fluids. Get daily weights, track INO, and check serum sodium frequently.
Constant vigilance for cerebral edema. Okay. Now, the opposite. Hyponatremia. Sodium below 135.
Hyponatremia, low sodium. This happens either from excessive water gain or retention. Think SIADH, syndrome of inappropriate antidiuretic hormone, stroke, certain lung diseases or cancers where the body holds onto too much water, diluting the sodium.
Dilutional hyponatremia.
Or excessive sodium loss, like from vomiting, diarrhea, burns, pancreatitis, cystic fibrosis, or adrenal problems. Certain medications, too, especially prolonged use of diuretics loop, thiazide osmotic, or the seizure med carbamazepine.
So too much water or too little salt. Symptoms, also neurological focus.
Yes, neurological symptoms are again prominent and dangerous because low sodium causes water to move into brain cells, making them swell. You can see seizures, coma, agitation, restlessness, headache, muscle twitching, altered mental status, confusion, irritability. There's a very real risk of brain swelling and brainstem herniation, especially when sodium drops below 120.
Brain swelling and herniation risk below 120. That's critical. Other signs.
Cardiovascularly, hypotension, tachycardia, orthostatic hypotension. Others include muscle weakness, anorexia, nausea, vomiting, abdominal cramps.
How do we treat low sodium?
Depends on the cause and severity. Generally, sodium replacement is needed. If it's dilutional hyponatremia, meaning they're fluid overloaded, then fluid restriction is the primary treatment.
Fluid restriction for the overload type. What about severe cases?
For severe hyponatremia, like serum sodium below 110, you might administer prescribed IV hypertonic saline solutions like 3% HEL. but this has to be done extremely cautiously. Warning: rapid correction is associated with osmotic demyelination syndrome.
ODS. What's that?
Osmotic demyelination syndrome. It's basically damage to the myelin sheath in the brain caused by rapid shifts in sodium. It can cause permanent brain damage. So slow, careful correction is paramount.
ODS risk with rapid correction. Another huge warning. Other treatments.
You might give loop diuretics like furosemide to help excrete excess free water. Absolutely institute seizure precautions and ensure a safe environment. And continuously assess that neurologic status for any changes.
Seizure precautions and constant neurochecks. Got it. Let's move to potassium, the intracellular cation.
Potassium, yes. Normal serum value, 3.5 millieql, and it's the most abundant contagion inside the cells. Crucial for nerves, muscle contraction, especially, as you said, the heart muscle and acid-base balance. Even small changes have big cardiac implications.
3.5 to 5. Critical for the heart. Let's talk hyperkalemia, potassium over 5, causes, and why the emergency.
Hyperkalemia, high potassium, can be from too much intake or potassium shifting out of cells. But the most common cause by far is decreased potassium excretion, usually due to chronic kidney disease, CKD.
CKD is the big one. Other causes.
Adrenal insufficiency, Addison's disease, diabetes if there's insulin deficiency, large blood transfusions, rhabdomyolysis where muscle breaks down, strenuous exercise, major trauma, burns, surgery, basically anything causing significant tissue destruction releases potassium.
Tissue destruction releases potassium. Makes sense. Meds.
Oh yeah, lots of meds can cause it. ACE inhibitors, ARBs, beta blockers, potassium-sparing diuretics, NSAIDs, certain antibiotics. Always check the med list.
Okay. And the symptoms. You emphasize cardiac?
Cardiovascular symptoms are the priority and are absolutely life-threatening. This is what hyperkalemia is a medical emergency. You look for classic ECG changes. Peaked or tented T waves, a prolonged PR interval, a widened QRS complex, flattened or absent P waves. It can quickly degrade into ventricular fibrillation and cardiac arrest. You might also see bradycardia or tachycardia.
Peaked T waves, wide QRS, V fibrillation, arrest. Okay,
Right.
Emergency status understood. Other systems.
Neuromuscular, muscle weakness, maybe flaccid paralysis, paresthesias, tingling, decreased deep tendon reflexes, GI nausea, vomiting, abdominal cramps, diarrhea, also fatigue, chest pain, dyspnea, hypotension.
How do we treat this emergency?
First, remove the source of excess potassium, if possible. Stop AV potassium hold offending meds. Then immediate action. Administer the FEITH calcium gluconate or calcium chloride immediately. This doesn't lower potassium, but it stabilizes the cardiac membrane and reduces the risk of those deadly arrhythmias. Buys you time.
Calcium first to protect the heart, then lower the potassium.
Exactly. You need to shift potassium back into the cells. You do this by giving IV insulin along with glucose to prevent hypoglycemia, or by giving nebulized albuterol.
Insulin glucose or albuterol to shift K+8 and get rid of it.
Right, remove potassium from the body. You can use potassium-binding resins like sodium polystyrene sulfonate, kioxalate, given orally or rectally to promote GI excretion, but watch out for the rare but serious risk of intestinal necrosis. Loop diuretics like furosemide help if the kidneys work. And hemodialysis is the definitive treatment for refractory hyperkalemia or an end-stage renal disease.
Kioxalate, loops, or dialysis to remove it,
Right.
and monitoring.
Institute continuous cardiac monitoring, including telemetry, absolutely essential. Get serum potassium levels frequently, like every 2-4 hours, until it's stable.
Telemetry and frequent labs. Got it. Now, hypokalemia, potassium below 3.5, what leads to that?
Hypokalemia, low potassium, often caused by excessive GI losses, vomiting, diarrhea, NG suctioning. Medications are a huge factor, especially potassium-wasting diuretics loop and thiazide diuretics are notorious.
Loops and thiazides again? Other meds?
Corticosteroids, insulin, it shifts K+ into cells. Laxative abuse, albuterol, epinephrine, some antibiotics. Also, acid-base imbalances, particularly metabolic alkalosis, cause potassium to shift into cells.
Metabolic alkalosis link. Interesting. Other causes?
Chronic kidney disease patients on dialysis can lose potassium. Cushing syndrome, hyperaldosteronism, severe magnesium deficiency MG is needed for K+ uptake and extensive burns.
Magnesium connection noted. Symptoms. Again, cardiac focus.
Absolutely. Cardiovascular priority. You're looking for cardiac arrhythmias. ECG changes include flattened or inverted T waves, depressed ST segments, prominent U waves, and a prolonged QT interval. Can cause palpitations, tachycardia, bradycardia, and potentially cardiac arrest. That prolonged QT interval carries a significant risk of torsades de pointe, a dangerous ventricular tachycardia, especially if magnesium and/or calcium are also low.
Flat T, U waves, long QT, torsades risk. critical cardiac signs.
Neuromuscular.
Muscle weakness, recurrent cramps, paresthesia, hyperreflexia, decreased reflexes, even flaccid paralysis in severe cases. GI, nausea, vomiting, anorexia, constipation, alias, other. Polyuria, thirst, fatigue, orthostatic hypotension.
Treatment for low potassium. Potassium chloride replacement, either oral or IV. For 5E potassium, you have to be careful. Ensure proper concentration usually shouldn't exceed 40 MEqL in the IV bag and infuse it slowly, typically no faster than 10-20 milliquar outside of emergencies, and always use a pump. Never IV push potassium.
Never IV push potassium. Max concentration 40 milliQL, slow infusion.
Notation.
What about that magnesium connection?
Crucial. Administer magnesium sulfate if concurrent hypomagnesia is present, especially if there are arrhythmias. It's very difficult to correct low potassium if magnesium is also low.
Replace magnesium too if needed. Other options?
You might use potassium-sparing diuretics. Institute continuous cardiac monitoring with telemetry is a must. And because of the muscle weakness, implement fall safety measures.
Telemetry and fall precautions.
Yeah.
Okay. Last one, magnesium. The enzyme activator?
Magnesium, yes. Normal serum value, 1.5, 2.5 millieql. Most of it's inside bones and cells. It's involved in tons of enzyme reactions, cell metabolism, ion transport in the kidneys, and importantly, it's essential for parathyroid hormone, PTH synthesis and release. Kidneys get rid of the excess.
1.5 to 2.5. Essential for PTH. What defines hypomagnesemia? Magnesium below 1.5. Causes.
Hypomagnesemia, low magnesium, a really common cause is chronic alcoholism. Also, GI disorders, acute or chronic diarrhea, malabsorptive syndromes like Crohn's or celiac, starvation, malnutrition, acute pancreatitis.
Alcoholism and GI issues.
Meds, yes. Prolonged use of loop or thiazide diuretics can waste magnesium. And proton pump inhibitors, PPIs, used long-term can impair absorption. Other causes include severe dehydration, sepsis, serious burns, uncontrolled diabetes.
Diuretics and PPIs, symptoms, neuromuscular again?
Yes, increased neuromuscular excitability is key. You see muscle weakness, tremors, twitching, leg-foot cramps. Interestingly, often hypoactive deep tendon reflexes early on, but can progress to hyperactive signs like positive Schwastek's sign and Trousseau's sign as it worsens.
Schwastek's and Trousseau's again. Cardiovascular.
Tachycardia, arrhythmias, including torsades like with low K+, hypotension, potentially cardiac arrest. Respiratorily, watch for respiratory depression. Severe cases can lead to laryngeal stridor, seizures, and coma.
Seizures, coma potential, any key warning?
Yes. Warning. Low magnesium can significantly increase digoxin toxicity. Be super vigilant for signs like nausea, vomiting, or bradycardia in patients on digoxin with low magnesium.
Digoxin toxicity risk, huge point. Treatment.
Administer magnesium replacement. Oral supplements for mild cases, or IV magnesium gluconate or magnesium sulfate for more severe deficiency or symptomatic patients.
Magnesium replacement, priority interventions.
Priority. Institute safety measures. That means seizure precautions and fall precautions due to the neuromuscular and potential CNS effects. Maintain a patent IV line for the magnesium infusion or fluids.
Safety first. Anything special about giving IV magnesium?
Yes, a practical point. When preparing magnesium sulfate 4, always clarify the order. Make sure it specifies the dose in grams or milliliters and the concentration, not just give 1 ampule or give 1 vial, as concentrations vary, prevents errors.
Clarify the MGSO4 order. Good advice.
And keep emergency equipment nearby for airway protection. Think ambu bag, suction in case of respiratory depression or laryngeal stridor. Monitor serum magnesium levels closely, especially if they're on diuretics or PPIs.
Airway equipment ready. Okay, last imbalance. Hypermagnesemia, magnesium over 2.5.
Hypermagnesemia, high magnesium. The most common cause is kidney disease, especially CKD. The kidneys just can't excrete it effectively.
CKD again, other causes.
Excessive magnesium intake or administration, like overdosing on magnesium-containing antacids or laxatives, milk of magnesia, Mylanta, or getting too much IV magnesium sulfate, maybe during treatment for preterm labor or eclampsia. Also, acute kidney failure, adrenocortical insufficiency, severe dehydration with low urine output, or even Epsom salts poisoning.
Overuse of laxative antacids or IVMG.
Yeah.
Got it. How does it present?
It's kind of the opposite of hypomagnesemia. It causes depression or relaxation. Cardiovascularly, bradycardia, hypotension, cardiac arrhythmias, potentially cardiac arrest in severe cases, neuromuscularly, diminished or absent deep tendon reflexes, muscle weakness, flaccid paralysis, and critically, paralysis of the respiratory muscles.
Diminished reflexes, muscle weakness, respiratory paralysis, respiratory impact.
Yes, respiratory depression leading to respiratory arrest is a major danger. Other signs: drowsiness, lethargy, confusion, nausea, vomiting, maybe facial paresthesia.
Respiratory depression is key danger. Treatment. Priority.
Priority. Discontinue any source of magnesium, stop the IV infusion, stop the oral supplements, antacids, laxatives.
Stop the magnesium source, then what?
Administer the 5-calcium gluconate immediately. Just like with hyperkalemia, calcium acts as an antagonist at the cardiac level, reversing the dangerous effects of high magnesium on the heart muscle and conductivity.
5-E calcium again for cardiac protection. How to get rid of the magnesium?
Prepare for hemodialysis if levels are dangerously high, if there's severe kidney failure, or if other measures aren't working fast enough. If kidney function is adequate, you can give IV fluid hydration, like normal saline, along with loop diuretics, like furosemide, to promote renal excretion.
Fluids and loop diuretics if kidneys work, dialysis if not. What about breathing?
Prepare for mechanical ventilation if respiratory function is significantly compromised or fails due to muscle paralysis.
Ventilation support if needed. Monitoring.
Monitor vitals and heart rhythm continuously with telemetry. Monitor urine output, closely notify the provider if it's less than 30 ml/hour, as that means the kidneys aren't clearing the magnesium. Assess the neuromuscular system, frequently check those DTRs, muscle strength, evaluate mental status changes, and maintain safety measures for falls.
Monitor urine output closely. Final point.
Yes, patient teaching is vital. Educate patients, especially those with kidney disease, about avoiding magnesium-containing medications, particularly over-the-counter antacids and laxatives.
Patient teaching on hidden magnesium sources. Excellent. Wow. That was a lot. A real power hour packed with absolutely critical information for your exam.
It really was.
Yeah.
And, understanding how all these systems, acid-base, fluids, electrolytes, are so tightly interconnected, it's not just about passing the test. It's fundamental to making safe, life-saving decisions for your patients every day. Every single detail matters.
Couldn't agree more. So as you're reviewing, really think about those connections. Don't just memorize isolated facts. Ask yourself, how does correcting metabolic acidosis impact potassium? How does giving diuretics for fluid overload affect magnesium and potassium and sodium? See how managing one thing creates ripples across the whole system? Take some time, review your notes, trace those connections. You've absorbed a huge amount today. You are ready. You've got this.